Question: A 45-year-old woman with a history of hypertension presents to the emergency department with a sudden onset severe headache, altered mental status, and vomiting. On examination, she is disoriented, has neck stiffness, and positive Kernig and Brudzinski signs. A non-contrast head CT scan is performed, which shows no acute findings. What is the most appropriate next step in the evaluation of this patient? A. Immediate lumbar puncture. B. Initiation of antihypertensive therapy. C. Neurosurgical consultation for craniotomy. D. Initiation of anticoagulant therapy. The most appropriate next step in the evaluation of this patient with sudden onset severe headache, altered mental status, neck stiffness, and positive Kernig and Brudzinski signs, despite a non-contrast head CT scan showing no acute findings, is A. Immediate lumbar puncture. A. Immediate lumbar puncture. This patient's clinical presentation, including a sudden onset severe headache, altered mental status, neck stiffness, and positive Kernig and Brudzinski signs, raises concerns about the possibility of subarachnoid hemorrhage, SAH, even if the initial non-contrast head CT scan did not show any acute findings. The rationale for choosing immediate lumbar puncture, option A, is as follows. Sensitivity of imaging. While a non-contrast head CT scan is often the initial imaging modality used to evaluate patients with suspected SAH, it may not always detect early or subtle bleeding in the subarachnoid space. Lumbar puncture is more sensitive for detecting small amounts of blood in the cerebrospinal fluid, CSF. Clinical suspicion. The patient's clinical presentation, including altered mental status, neck stiffness, and positive Kernig and Brudzinski signs, strongly raises suspicion for SAH, which is a medical emergency. Delaying the evaluation and diagnosis of SAH can lead to poor outcomes. Options B, C, and D are not the immediate next steps in the evaluation of this patient. Initiation of antihypertensive therapy, option B, may be necessary if the patient has significantly elevated blood pressure, but it should not replace the need for further evaluation, including lumbar puncture, to rule out SAH. Neurosurgical consultation for craniotomy, option C, may be warranted if SAH is confirmed and the source of bleeding needs to be addressed surgically. However, this should follow the confirmation of SAH through lumbar puncture. Initiation of anticoagulant therapy, option D, is not appropriate in the absence of a confirmed diagnosis. Additionally, anticoagulation therapy can increase the risk of bleeding in the context of SAH. In summary, given the high clinical suspicion for SAH and the limitations of the initial imaging, immediate lumbar puncture is the most appropriate next step to definitively rule out or confirm this potentially life-threatening condition.